At the end of this talk, you will be able to define permanent family planning methods. You will also be able to identify male and female permanent family planning methods. You will be able to describe the benefits and the risks of permanent family planning methods. At the end of this talk, you will be able to explain the techniques of vasectomy and female sterilization. At the end of this talk, you will be able to identify some of the misconceptions of permanent family planning methods. So, what is permanent family planning? Permanent family planning are surgical procedures to permanently and intentionally terminate male and female reproductive function. It is done appropriately for men and women who have made a fully informed and well-considered decision. This method of contraception is non-reversible and permanent. When done right, successful infertility rates for vasectomy are over 98%. The failure rates are less than 1%. As I mentioned, most are not reversible. So permanent family planning includes vasectomy for men and bilateral tubal ligation for women. We shall know what vasectomy means and what bilateral tubal ligation means. So vasectomy. For men who do not desire to have any more children, vasectomy includes or involves transection and occlusion of the vas deferens. The vas deferens are small small tubes that connect the epididymis that lie right above the testis to the urethra, through which the sperm are ejected during sexual intercourse. Also called male sterilization or male surgical contraception, this is mostly an outpatient procedure that is usually done under local anesthesia. One of the misconceptions about vasectomy is that it interferes with sexual performance. This is not right, because vasectomy, during the procedure, only the tubes, only the vas deferens are ligated, so that spermatozoids that are being formed in the testis and stored in the epididymis cannot be able to move through the urethra and during ejaculation. Sexual performance in males is conserved because the testes, which are the main source of the gonadal hormones for males, are not affected, and therefore sexual performance is not affected in a vasectomy. Unfortunately, this is one of the least used forms of contraceptions in Rwanda. Some of the techniques for vasectomy include scalpel and non-scalpel. The difference between scalpel and non-scalpel is that scalpel involves making a large incision on the scrotum bilaterally, and non-scalpel, only a small pinhole incision is made. Non-scalpel techniques have the least amount of blood loss compared to scalpel. The technique involves palpating the vas through the scrotum. So you need to palpate for the vas after making a small incision through the scrotum and separating the different layers of the scrotum. The vas is then grasped by either fingers or a non-tooth forceps. The loop of vas is then pulled through the incision, and a small segment is incised. Both ends of the vas are then ligated and then later buried back into the scrotum. So, as I mentioned, this anatomic picture of the male reproductive tract shows the vas deferens. The vas deferens, as I said, is a tubule connecting the testicle and it transports. Sperm are usually made in the testicle. After spermatogenesis, the sperm are stored in the epididymis, where they mature and are ready for fertilization. During ejaculation, the seminal fluid flows through the vas deferens and into the urethra, and then ejected into the vagina during sexual intercourse. Now, the vasectomy that is done only involves the vas deferens. By ligating the vas deferens, spermatozoids are not able to move from the epididymis, where they have been stored, and to the urethra and into the vagina during any sexual encounter. However, there are indications for delaying a vasectomy. In case of active sexually transmitted infections, it would be safe to postpone the procedure. You need to treat appropriately the infection before you do the procedure. Swollen and tender testes are typical signs of epididymocarditis, a bacterial infection of the testis and the adnexa. So again, before doing any procedure, you need to treat appropriately these infections before doing the procedure. Scrotal and skin infection, just like any other invasive procedure, you need a sterile environment. An infected skin is a potential hazard, a potential source of surgical site infection. You need to treat this before you do the procedure. And of course, if the testes are descended, then the procedure is a very difficult one to do. So what are some of the benefits of vasectomy? As I mentioned, the failure rates are less than 1%. Unfortunately, if the procedure fails, there are 3 reasons why the procedure would have failed. First of all, unprotected intercourse soon before azoospermia is documented, which is approximately 3 months. So the theory is, when you do a vasectomy, there could be remnants of spermatozoid that stay in the vas deferens or even in the urethra that can potentially cause fertilization. So it is always safe to use another contraceptive method at least in the first 3 months until there has been definitive documentation of azoospermia. Failure to occlude the vas. This is usually a technical error, or in very rare instances, there could be recanalization. The other thing I have to mention is that vasectomy is safer and more effective than tubal ligation. First of all, because it's a less invasive procedure, it can be done by outpatient. There are no risks involved with anesthesia because it's only you only sometimes need local anesthesia, while tubal ligation requires general anesthesia, and this can expose the patient to all the risks that go with it. So the death occurring secondary to vasectomies are extremely rare, about 0.5 per 100,000 vasectomies. Some of the complications of vasectomy include bleeding. These are very rare, very uncommon, but they could happen. Like any other surgical procedure, bleeding may result from the procedure. Some of the bleeding is very mild, requiring only limited intervention. Some bleeding may be very severe, resulting in huge hematoma formation. We have seen complications that require exploration of the entire scrotum. So testicular and scrotal pain lasting for months. We call this post-vasectomy pain syndrome. Post-vasectomy pain syndrome result as a result of the fact that even after vasectomy, there is a continuous process of manufacturing of spermatozoid by the testis. The continuous production of spermatozoid by the testis sometimes means that they become heavy, they become occluded, and they can cause dull aches that may last for months, or even for months or even weeks. Some patients report it even for years and may require non-steroid anti-inflammatory drugs to relieve the pain. Surgical site infections. Like any other invasive procedure, surgical site infections could occur as well. I mentioned hematoma or sperm granuloma. Spermatozoid are very spermatozoid are very inflammatory, causing cells. This may result into large granulomas as a result of leakage of spermatozoid into the neighboring tissue. This can cause granuloma, and in many cases it is characterized by small swelling that patients may palpate in their testes. However, many of these sperm granuloma are asymptomatic. While symptomatic, they could require some pain medication. So you need to confirm sterility. So 80% of patients that have undergone vasectomy are azoospermic after 3 months and 20 ejaculations. What do I mean by azoospermia? Azoospermia is defined as sperm count less than 10,000 motile sperms. So a semen analysis ideally is done 3 months post-operatively, and during this time another form of contraceptive, as I mentioned, should be used. Vasectomy is considered as failed if motile sperm are confirmed on the follow-up examination. There have been a sufficient number of ejaculations, over 20, and over 3 months have elapsed since the procedure has been done. So, to confirm that the procedure has been successful, the patient will have to return for a follow-up visit where a semen analysis will be done to confirm that there are no potentially viable spermatozoid in their semen. If there are more than 10,000 motile sperm, the procedure is repeated after another month, and if it still confirms that there are more than 10,000 motile sperm, the procedure is considered to have failed. The patient should be advised to use other methods of contraception. What is female sterilization? For women who do not desire to have more children or have children at all, it is a surgical tubal ligation. So it involves occlusion of the fallopian tubes in some form. So it could be tubal ligation, it could be using scalpels, it could be using any other form. But the basic is that the fallopian tubes are occluded. In the female genital tract, when ovulation occurs in the ovaries, the ovum is released into the fimbria and then into the fallopian tubes. When there is coitus, the male spermatozoid migrates through the uterine cavity, and fertilization occurs in the fallopian tubes. By occluding the fallopian tubes, you are forming an anatomical barrier so that the male spermatozoid and the female ovum do not meet. This is what we call female sterilization. It's most widely used globally, about 210 million couples, and in the US about 28% of all the contraception methods used in the US are permanent or female sterilization. However, it is the least popular in Rwanda and accounts for only 0.1%. So methods of tubal ligation. It is important to learn the methods of tubal ligation because this is a technique that is done by mostly general practitioners who perform cesarean sections and may need to do bilateral tubal ligation. There are 4 methods. The Pomeroy method, which is the most widely used method, unfortunately, it is also the one with the highest failure rate. The Parkland, also called the modified Pomeroy method, the Irving method, and the Orchida method. We're going to look at these in detail in the following slides. So, the Pomeroy method. The Pomeroy method involves taking the segment, as you can see from the illustration, taking the segment of the tube and forming a knuckle. The segment of the tube is then excised and the ends of the ends of both tubes are then tied. This is called the Pomeroy method. The modified Pomeroy method, also called the Parkland method, is similar to the Pomeroy, but the segment of this tube is ligated at 2 points instead of jointly as a knuckle. The Irving method, also another method of tubal ligation, involves looking at externalizing the tube and ligating the tube and burying the tube, both ends of the ligated tubes into the broad ligament. The Orchida method, which is the most complex method but with the most extremely low failure rate, involves taking the tubes, looking at the end, and then ligating both tubes while burying both tube ends into the broad ligament. Some of the pitfalls include significant bleeding, which may arise from trauma onto the underlying small vessels from the ovarian artery that could cause potentially significant bleeding. This, however, requires a lot of expertise and is the most complex method. However, it is associated with the lowest failure rate. So when is female sterilization done? It could be done at the time of cesarean section. Also, postpartum bin laparotomy, which is done immediately after delivery or within 24 hours. It may be done up to 7 days later. Or it could be done as an interval-min laparotomy and related to pregnancy. This is any time after and it's not related to pregnancy. Or it could be done post-abortion. So postpartum minimal laparotomy done immediately after the delivery is the most widely used method. So min laparotomy for tubal ligation. So ligation of the fallopian tubes is done through a 3 to 4 centimeter incision on the abdomen and can be done as an outpatient procedure with local anesthesia and sedation. Minilateral following vaginal delivery. Here, the surgeon takes advantage of an enlarged uterus because the uterus, which is not yet completely involuted, is right below the umbilicus. So accessing the uterus, the fundus of the uterus and both tubes is very easy through a 3 to 4 centimeter subumbilical incision. Interval laparotomy, as I mentioned, done unrelated to pregnancy, also involves making a short transverse suprapubic incision. Unfortunately, sometimes this may end up as a laparotomy, especially if the woman is obese or the procedure is very difficult. In any case, you need a uterine elevator which is inserted through the vagina to help elevate the uterus. So what are the indications for delaying tubal ligation? Of course, you cannot do a tubal ligation when there's an ongoing pregnancy or less than 6 weeks postpartum. In severe postpartum or post-abortion complications, these need to be treated first before doing the tubal ligation. Unexplained vaginal bleeding in case of pelvic inflammatory disease and sexually transmitted infections, and also when you have pelvic malignancies, could be adnexomas, ovarian masses, or uterine, any other tumors arising from the uterus. Female sterilization has no known side effects. It helps to protect against unwanted pregnancy, and the patient has nothing to remember. They don't have to worry about taking contraceptives again. Significantly, it reduces the risk of pelvic inflammatory disease. Also, female sterilization has non-contraceptive benefits, which include protection against epithelial ovarian cancers. About 5 to 15% of all epithelial ovarian cancers are thought to originate from the fallopian tubes. By ligating, the mechanism by which they protect against epithelial ovarian cancers is not known, but we think that it is, the theory is by taking up part of the tube, it theoretically reduces the woman's risk of developing epithelial ovarian cancers. Some of the complications involved include those that are related to surgery or anesthesia. And as I mentioned, previous surgeries make the procedure very complicated and risky, as it may involve injury of the underlying organs. Pelvic inflammatory diseases cause a frozen pelvis. Dense pelvic adhesions make the procedure very risky and may cause injury to the underlying organs. Obesity and diabetes mellitus. All these are risks from these morbidities, not directly related to the procedure itself. So again, the mortality is about 1 to 2 deaths in 100,000 cases, and the failure rate I mentioned is less than 1%. It's about 2 pregnancies per 100 women over 10 years. And the possibility of future regret. As I mentioned, this is a non-reversible method, and given that it's non-reversible, there could be future regret. the woman may regret having taken the decision, especially if it is done at a very young age, or if a woman lost her child, or sometimes when the woman has few or no children at all. It has been postulated, it has been shown in many studies, that when unmarried women take this decision, or those who have marital problems, their risk of regretting in the future also is greatly increased. Therefore, it is important that the mother makes an informed consent before taking this decision. It should include explanations to the mother about the potential risks, the benefits, the possibility of later regret, and the possibility of failure, which may result into an ectopic pregnancy. When the mother is not fully consented for her decision, as a good doctor, as a good clinician, you should counsel her about other alternative methods of contraception. As summary, as take-home message, permanent methods are potentially irreversible. Non-scalpel vasectomy in men and bilateral tubal ligation for women are preferred. So non-scalpel, as I mentioned, because it is associated with the least blood loss. Permanent methods are the least popular in Rwanda. Before doing the procedure, detailed counseling is very essential and important. Mothers, women have to be consented to understand the procedure and to clearly know that this is an irreversible method, and therefore they should understand the benefits and some of the risks involved. While there are some complications, they are extremely rare, and in most cases are not related to the method. Thank you for following this presentation. And now, I want to leave you a case study. You have a 20-year-old woman come to your clinic for family planning. She and her family decide that tubal ligation is best for them. The couple has one child. So what important issue would you like to raise during the counseling? To pause this video and take a 3-minute break as you think through this. Importantly, it is important to know that you check if it is well thought through by the patient, discuss the possibility of future regret as the method is irreversible, and then mention other alternative family planning methods that are equally efficient before offering the mother permanent family planning. Thank you for your kind attention.